Not many people have actually ever met a pathologist. I made this joke 2 years ago, but this is one in the flesh. This is Dr. Cummings. He's important to our division. I base a lot of clinical decision-making on what he tells me, and I trust him greatly. But he has a special focus in liver and GI diseases, specifically also in transplant pathology, and again, is truly just an integral piece of the clinical care of AIH patients. So if you'll join me in welcoming Dr. Bill Cummings.
Can everybody hear me? Great. Well, Craig, thank you very much for that kind introduction. It's really a pleasure for me to be here. As he said, I am a pathologist, so I don't get out very much. Most of my time is spent looking through a microscope and talking to the clinicians. Obviously, I don't see patients, so to be here in front of the patients is really a privilege, and thank you very much. So let's see here. Here we go. So in thinking about this, I realized that most of the patients with autoimmune hepatitis probably had a liver biopsy, and I thought you might be interested in knowing what happened to that specimen after they took it out of you. So I'm going to go through that a little bit. And then secondly, after you got the biopsy, you probably got a bill, and you looked through the bill and you said, who the heck is Dr. Cummings and why should I pay him? And I'm hoping that after I've gone through some of this, you realize what the role of the pathology is in helping to manage autoimmune hepatitis and hopefully justified the fee. So that's what we're going to try and do. So after you got your biopsy, do I have a pointer here? Maybe not. No pointers? So, okay. Wonderful. Thank you. So they put it in a little vial of formaldehyde, and this we use it to solidify the specimen. It cross-links a lot of proteins. And they also put a label on it with your name. And when it got to us in pathology, we put our own label on it. We gave you a number, unfortunately. And we have the same number on your paperwork, and we put it on what we call cassettes. And the other thing I want to just briefly mention for my colleagues is it's very helpful if you write down some history. If it just comes in blank, it says liver biopsy, it's not very helpful, and sometimes we don't know exactly what to do. So the more history we get, the better off we are. And so we take the specimen out of the jar, and we put it in the cassette, and all the numbers stay the same, and that's how we track things. And then we take the cassettes at the end of the day. We got several hundred of them, and we load them in this kind of machine. We have several machines, but this is one of them. We process about 1,000 blocks a day. And we put in this machine, and we run it overnight. And there's chemicals that you can see in different vials here. And the chemicals are pumped in one at a time into the vat. They sit there for half an hour. They're pumped out. And the next chemical is pumped in. And at the end of the night, we've removed all the water from the tissue, and we've removed all the lipid. And we have wax in the containers here, and those components, the water and the lipid, are replaced with wax. So now we have a little waxy piece of liver. And we take it out of the cassette, and we put it in a mold, and then we put the cassette back on top of the mold, and we fill everything up with wax. So we have your number on the cassette, and your liver specimen is embedded in wax on the back side of this cassette. And then we put it in a machine we call a microtome. It's sitting right in there. That cassette fits perfectly in there and is held tightly. And there's a razor blade there. And a technologist cuts a thin shave of the liver biopsy off and floats it in this water bath. And then they take a glass slide. It's a very thin, clean glass, and it has that same number on it that was on the cassette, and they pick the tissue up there. And then we put it on this robotic auto stainer here, and we use red and blue dyes to stain the tissue. It melts the wax off, and so we have this thin piece of liver that's 5 microns thick, stained with red and blue dyes. And that's how we get the material to look at from your liver biopsy. And the other thing that's interesting is that this block is an archive thing. So if we need some future discovery comes along in 5 or 10 years, we can go back and still have the liver specimen that you provided. We have these going back to the 40s from everybody that we've ever taken care of. And we can go back, and there's amazing things you can get out of this today that you couldn't get out of them 10 years ago. So a lot of the DNA technology works on these paraffin blocks. So this may be a valuable resource going forward. And then I sit in my office and I look at the slides through my microscope. It's a nice scope. I got binocular head. I got a digital camera and a place for the resident to look. And you can see how the slides are arranged in my tray, and this is how I spend my day. So that's how that part of it works. Well, this is how it started out. This was the first microscope back in the 1600s. There's a little glass lens there, and the specimen was put on this needle. And that's how microscopy started. And the whole idea is that the tissue like the liver, the organ like the liver, it's made up of cells, and cells beget cells, if you will. And here's what a typical cell looks like. You've seen some of these pictures before and been alluded to earlier. But there's a nucleus in the center that holds the DNA, and then the cytoplasm on the outside that holds sort of the cellular mechanisms, the area where the cell does the work that the cell does. And depending on where it is, the cell does different things. And if an organized collection of cells is a tissue, and then the study of tissues is histology, and the study of abnormal tissues is histopathology, and that's what I do. So here's what your liver normally looked like, a little basic pathophysiology. I hope this isn't too basic. Relatively normal liver. The white holes you see here are fat. That's not entirely normal, but it is Indiana. So anyway. But other than the fat, this is a pretty much normal section of the liver. And I just wanted you to appreciate how the tissue is organized. So the worker bee or the work cell is the hepatocyte. They're arranged in rows. There's a single hepatocyte lined up along the others. And then there's a blood sinuses, they're called. A row of hepatocyte sinuses, row of hepatocyte sinuses. Can't exactly see it here, but that's how it's arranged. And this is where the work of the cell is done. The hepatocyte does all those things that Dr. Holden told you about, all those proteins that are made, all the cell processes that are done, the detoxification of things. The bilirubin is handled by this cell. So this is the workhorse. And when it makes the bile, it secretes it out into little canaliculi that you can't actually see at this level in a normal thing. And the bile travels back along these little canaliculi, and it gets collected in the bile duct. And so here's what we call a portal tract. And each portal tract has a bile duct, a branch of the hepatic artery, and a branch of the portal vein. And so the bile collects in this little small duct, and it feeds back into bigger and bigger ducts until it empties out in your common bile duct in the duodenum. So that's normally the way the bile is handled. And the blood flows into the liver through the vein and the artery, and then it percolates through those sinuses that you can't really see, and then it collects in the hepatic vein, and then that collects into bigger and bigger veins and returns to your heart. So this is the basic pathophysiology of the liver. And I'd like you to notice that the normal portal tract is kind of small, sort of triangular shaped, and there aren't a lot of cells in it besides just these structures that I pointed out to you. So hopefully normal. And we use some special stains. People have alluded to this earlier. This is a trichrome stain that stains collagen, and collagen sort of equates with fibrosis, except there is some normal collagen in the liver. So this is a portal tract, and normally it has type 1 collagen, which is what we equate with fibrosis. So the normal portal tract should have that, and there's a little bit around the central veins. The rest of the liver shouldn't have any collagen in it. So again, kind of normal looking stuff. And we talked about the diagnosis of autoimmune hepatitis before. I'm going to touch on just a few things about this. Most autoimmune hepatitis is a chronic disease. People have talked about the clinical presentation, sort of fatigue, it's like a slow onset. and then elevations of the transaminases. And so that's usually what I'll talk about mostly. And I'll emphasize the staging and the grading. How active is it and how advanced is it? I also wanted to mention a few things that haven't been touched on as much, at least that I've heard. Acute autoimmune hepatitis, which used to be controversial, but I think most people believe in that now, and fulminant autoimmune hepatitis. We heard a wonderful talk about the overlap syndromes, and I just want to mention that briefly. I will just say a few words about drug-induced autoimmune hepatitis, and this hasn't been touched on that I know about, but I'll get to that at the end. So I put this slide in. This is from a wonderful paper that's available free on the Hepatology website. Anybody can read through it. And it just deals with the liver biopsy, what clinicians and radiologists and pathologists can expect from the biopsy. I don't know if the lay public would find it interesting. But I show this to the medical students because a lot of physicians, not hepatologists, but in general physicians, have this idea that if you do a liver biopsy, you'll magically be able to get the answer back from the pathologist. And that really isn't the case. The liver biopsy really doesn't provide a diagnosis in a lot of things. It's certainly helpful in autoimmune hepatitis, fatty liver disease, and transplant. But other than that, you're not going to get a specific diagnosis out of a biopsy, a liver biopsy. It's mostly for staging and management and prognosis, and you can see that's a big role for the liver biopsy in autoimmune hepatitis. So a little preaching. So again, this has been alluded to previously as well. I won't go through all the clinical components of making a diagnosis of autoimmune hepatitis, but these are some of the histologic features. Some of these have been touched on before, and I'll just show you these things in a little bit more detail. So this is what a typical low-power view of the liver is. If you remember the normal that I showed you, there weren't many cells in the portal tracts, but in this case, you can see all the portal tracts are greatly expanded. They're no longer triangular. They have this kind of odd maple leaf kind of shape to them, as you can see here. And they're filled with these blue dots. And an aphorism in pathology is blue is bad. So these are the bad cells. And here we are at the edge of a portal tract. Here you can see a branch of the hepatic artery. Here's the interlobular bile duct. And then you see this big infiltrate of cells. And if you could remember, in the normal liver, the interface between the portal tract and the lobule where the hepatocytes were was very smooth, very sharply demarcated. There was the collagen of the portal tract and then the hepatocytes in the lobule. Here you can see this is where the interface should be between the portal tract and the lobule, but it's not smooth anymore. There's this big infiltrate, and it's got a real irregular, ragged border. This is called interface hepatitis here. And this is one of the main things that we look for histologically to make a diagnosis of autoimmune hepatitis. Here is what's called a hepatocyte rosette. Instead of being a long trabecular structure, it's rounded up. Here's another one over here that's been trapped. And you can also see that there's a lymphocyte. And remember, Dr. Lambert referred to T cells being the effector cell. This is a lymphocyte. I can't tell if it's a T cell or B cell by looking at it. That's infiltrated the hepatocytes. This is called imperial polesis, which was one of the factors in the older literature, but I think it's kind of fallen by the wayside somewhat. And then you can see this dense inflammatory cell that the normal portal tract doesn't show. So these are the features that we want to see. And the big component of this infiltrate are plasma cells. And plasma cells are these cells here. This is the whole cell. And the nucleus is off to the side. It's not in the center of the cell anymore. The chromatin, or the way the DNA is arranged, has a kind of a clock face appearance. And there's a little clearing of the cytoplasm here that we call a Hoff, and then this deep purple cytoplasm. And these are cells that make immunoglobulin. And remember, we had elevations of the serum globulins and the serum autoantibodies. These are the cells that make those kind of things. So you can see the histology kind of helps put together some of the clinical findings. So these are the features that we look for to say it's compatible histology with autoimmune hepatitis, and then all the clinical factors come together to hopefully form a very specific diagnosis of autoimmune hepatitis. So we work together with the clinician to establish the diagnosis of autoimmune hepatitis. Then we grade the amount of inflammation that's there. This is the system I use. It's based off the Medivir system. There's many, many published systems, but this is what I use to say how severe the inflammation is, and it's based on how things look around the portal tract and how things look out in the lobule. The interface hepatitis I showed you a picture of. Sometimes it's patchy. Sometimes it completely affects the entire periphery of every portal tract. And then sometimes you get necrosis out in the lobule, and those are features of severe autoimmune hepatitis. And then we do the staging, and that's how much fibrosis is in there, and I'll show you a little cartoon about that. Again, I use the Medivir system. A lot of people use the Batts-Ludwig system. I'm one of 3 pathologists that look at the liver biopsies here. We look at about 1,700 liver biopsies a year. And I use this system, and my colleagues use this system. Hopefully the clinicians realize that these are not exactly the same, and I try to make clear that I'm using this system. And so wherever you go, whoever treats you, I just hope the hepatologist understands how the grading and staging is scored by their pathologist. So what about the fibrosis? So here's a cartoon where we're kind of trying to show our normal liver. The portal tracts normally have that kind of triangular shape. The central veins are here, and the hepatocytes would be here. And this is a repeating pattern. It's kind of like wallpaper. So in the normal liver, it sort of looks like that. But when you get autoimmune hepatitis, you saw all that inflammation that occurs predominantly in the portal tract. We injure the hepatocytes around the portal tract. They die off, and sometimes they're replaced by fibrosis. And it tends to be early on a periportal fibrosis, and it kind of comes out as little twigs of fibrosis, if you will. So it's not everywhere at first, but then it progresses, and as time goes on, you get more twigs and longer twigs of fibrosis, and sometimes the twigs bridge between 2 structures. So a fibrous bridge going from a portal tract to a central vein is bridging fibrosis. And so in the Medivir system, that would be considered an F2 fibrosis. Not everywhere, but now we're starting to get some connections between these anatomic structures. And as it progresses, you get more and more bridging. And eventually, there's fibrosis kind of encircling things. And so the central vein is no longer in the middle of a lobule. It's caught up into this big fibrous patch. And this is what we call cirrhosis. And I'll show you that. Here's a cirrhotic liver at a grossly. It's a cut surface of the liver. This is a cut section of the gallbladder here. And you can see this fine nodularity. So these nodules are about 3 millimeters or less in diameter, and that's a micronodular cirrhosis by definition. And microscopically, this is what it looks like. So here's where a portal tract was. This was a portal tract. That was a portal tract. And you see they get caught up in this fibrous band. And then there's no central vein in this regenerative nodule of hepatocytes. And again, this person has some fat. But there's no certain way to tell what causes cirrhosis when it gets this too far, and we rely on the history. And this is what the treatment is trying to prevent, this progression in fibrosis. So one of the things that I do is provide this kind of staging information for the clinician to kind of let him know where you are in the progress of your disease. And so a few things I wanted to talk about was autoimmune hepatitis, or acute autoimmune or fulminant autoimmune hepatitis. And originally it was thought that autoimmune hepatitis was always a chronic disease. But I think recently people have realized that there are some cases that look like clinically like acute hepatitis that turn out to be autoimmune hepatitis. And these tend to present much more acutely with nausea, vomiting. They may have jaundice. The patients that have fulminant disease often develop a coma, may or may not have fever. And the ALTs are generally very high in acute, but less than 1,000. And in cases with fulminant autoimmune hepatitis, the transaminases will be greater than 1,000. And when a clinician sees a patient who presents with nausea, vomiting, some jaundice, and greatly elevated transaminases, there's a wide differential diagnosis. And most people immediately consider hepatitis B or other hepatitis viruses and drugs like Tylenol or toxins. But I think sometimes they forget about autoimmune hepatitis, and it's important to remember that autoimmune hepatitis can also present in this fashion. So we weren't the first to make this point, but we had one of the biggest series of cases of acute and fulminant autoimmune hepatitis that we published in 2004. And I think this is caught on in general among the clinicians. And here's what this looks like. So it's a little different than the chronic hepatitis that we saw originally. It's a little hard to pick the structures out because there's been so much damage. You can see some hepatocytes here. Here's a central vein. It's hard to tell. I think there's a portal tract here, but then there's been necrosis all along here. Some hepatocytes, but there should be hepatocytes here as well, and there aren't any. And up closer, you can see there's a lot of inflammation. Again, lots of plasma cells in here. I think there's a bile duct there, but it's a little hard to tell. There's a bile duct there for sure. So here's a portal tract. And again, a higher power illustrating the irregular interface between the portal tract and the lobule. This is an interface hepatitis. You can see the lymphocytes in among the hepatocytes, plasma cells, so features of things that we associate with autoimmune hepatitis. But there's no chronicity here. So chronicity is fibrosis to a pathologist. Here's the normal portal tract, and you can see there's a normal amount of blue. There's this area of necrosis. There's no blue in here. So this is just collapse. It's not fibrosis. And I've seen people mistake this collapse for fibrosis before. I had a case that came to me. It was a patient who had a biopsy that was called cirrhosis, and a year later they had a biopsy that looked normal, and they couldn't explain it. But when I looked at it, it was just an acute autoimmune hepatitis with collapse, and they treated the patient, and it healed, and it didn't heal with fibrosis. It just healed up normally. And so I kind of solved that problem for them. But some pathologists will mistake collapse for fibrosis, and you don't want to do that. And then this is a case of fulminant hepatitis. This is someone who came to a transplant. And you can see there really aren't any liver cells left. They're just vascular structures and portal tracts. And the rest of the material that you see in between those vascular structures and portal tracts is just connective tissue. It's those blood vessels that were in between the trabecula and the normal liver. So this is sort of incompatible with life, and that's why they need a transplant. And here you can see a remnant of a portal tract. Here you can see the central vein, and all that's left is this connective tissue scaffolding. There are no hepatocytes left. So the liver can't do its functions. There's no hepatocytes to do all the work that Dr. Holden told you about. So I just wanted to point those kind of things out. Dr. Bacon gave us a nice talk about the overlap syndrome, so I won't say a whole lot about that. I was at a conference about 20 years ago for a pathologist named Jürgen Ludwig, who was very well known, even among hepatologists, I believe. And he was retiring, and they had a nice fete for him for his retirement. And there were very famous hepatologists there as well. Sheila Sherlock was there, and people came from all over. And there was a talk about overlap syndrome, and he said, "Oh, goody, I've never seen that." And I think he was just being facetious, pointing out the fact that it's not very well defined. And it's the same, I think, goes through to today. And as a pathologist, there aren't good criteria for diagnosing overlap syndrome. But I try to point out features that I feel might represent overlap syndrome in my report so the clinician can take that under consideration and act appropriately. And so I had pictures of that, but I dropped them out. And then drug-induced autoimmune hepatitis is always a consideration when anybody presents with liver disease and some serologic markers. There are well-known drugs that cause autoimmune histology and autoimmune clinical symptoms, so these always have to be excluded. I don't know about the natural history of these, but I presume a lot of these, if you withdraw the drug, the hepatitis clears up. So as opposed to your regular autoimmune hepatitis where you're on lifelong therapy. So I think it's important to recognize these. There's nothing I, as a pathologist, can do to recognize these drug-induced injuries. It just looks like autoimmune hepatitis histologically, and the clinician has to keep these things in mind and make sure you're not taking any of these medications. And then just this hasn't been touched on before, but I get this a lot, so I just wanted to mention this. This is a study we did from the NASH CRN It's certainly not the first of this, but it's the biggest study that's ever been done. And most patients with fatty liver disease, it's a completely different thing. But we found that about 20% of the patients had elevated serum markers for autoimmune disease. So we wondered, do these patients have two diseases, fatty liver disease and autoimmune liver disease, or is this just some spurious elevation of their serum markers? And so we looked at over 800 patients, and this is the largest, best characterized cohort of these fatty liver disease patients. And we find that it was very common to see these elevated serum autoantibody markers. But when we looked at the histology, it looked like typical fatty liver disease. It didn't look like the features I just showed you for autoimmune hepatitis. So we concluded that, and then when we followed these patients, most of them didn't behave like an autoimmune hepatitis. They weren't put on immunosuppression. They didn't develop fibrosis quickly any differently than fatty liver disease patients. So we concluded that these markers are elevated, and as long as the histology looks like fatty liver disease, they don't have concomitant autoimmune hepatitis. And I get this question, like, say, once or twice a week. And I don't know if all pathologists know about this, but it's an important part of my practice, so I just thought I'd mention that. And so I'm toward the end here. I hope I conveyed some understanding of how a pathologist can help in the management of your liver disease and some of the things that we do and what happens to your biopsy. And thank you so much for your attention. I appreciate it.